Good morning, friends. Welcome back to my favorite class. Please subscribe to my channel and also please give your valuable comments. You can also visit the playlist. In the playlist, I have provided almost all the topics in a very systematic order. You can also make use of it. Thank you very much. So last class, we were discussing about DMD. Now, in case of DMD, one important sign which is seen is called as valley sign. Actually, this sign is also called as Pradhan sign. So this is a matter of pride again, that Pradhan sign, name is given after an Indian neurologist. Okay, so in case of DMD, the patient is asked to abduct their arms. How to test this valley sign? The patient is asked to abduct the arms about 90 degree under flexion of the elbow at 90 degree. That means elbow should be flexed at 90 degree and abduction should be done about 90 degrees. So in this position, the muscles around the shoulders, scapula, axilla, and upper arms are inspected to get the specific pattern. So a linear groove or sometimes a oval depression running obliquely from the spinous process of the scapula towards the axillary lesion will be seen just like a valley. Just like a valley. So in the mountain area we have got the valleys. Just like the valley, a depression will be seen. Hence the name valley sign. This is due to the wasting of the muscles required in the formation of the posterior axillary fold. There will be atrophy of the muscles or wasting of the muscles which are actually forming the fold of the posterior axillary fold. So when they undergo atrophy and wasted, so this formation of manifestation. On the other hand, on the other side of the depression, the two prominent spots are visible. Okay, so inferior medial bulging is due to the hypertrophy of the infraspinatus muscle, and the superior lateral bulging is due to the hypertrophy of the deltoid muscle. So totally this gives a the picture of a valley. Okay, hypertrophy of the two muscles will be seen, and that means prominence of the two muscles will be seen, along with the wasting of the so many muscles. The whole appearance looks like a valley between two mountains. So between two mountains, the two mountains, one is hypertrophy of the infraspinatus muscle, another one is hypertrophy of the supralateral hypertrophy of the deltoid muscles. In between, the muscles which are required from the posterior axillary fold, so they are totally atrophied, and that leads to a valley sign. Now, if you look into the genetic etiology and pathogenesis, DMD and BMD are both basically passed through X-linked recessive disorders, but about 30% of the cases that may be because of the new mutation cases. Okay, yes, it is true that 70% of the cases are because of X-linked recessive trait only, but 30% of the cases DMD can occur because of new mutation. Therefore, sometimes it can be also seen in case of a female. So in 30% of the new mutation cases, the mother is not the carrier. Okay, so it is found that usually mother is a carrier, isn't it? But recessive trait, mother is a carrier. Now, in 30% of the cases of DMD, we see that mother is not at all the carrier when genetic study was done. So that suggests that new mutation was happening in this particular kid. So female carrier state usually does not show the muscle weakness or the other clinical symptoms. Now, a 427 kD cytoskeletal protein by name dystrophin, okay, 427 kD, that is a molecular weight. Cytoskeletal protein, cyto means cell, skeletal. This forms the skeleton of the muscle cell itself. Cytoskeletal protein by name dystrophin is encoded by the gene which is present in XP21, we have discussed previously also. This is also the subsacrolamella protein. This is the actual pathology. This protein, dystrophin, is a subsacrolemma protein which is attached to the sacrolemma membrane, which forms the actin and myosin bands of the myofibrils. Now, why this is so important? Because the attachment of this dystrophin with the muscle fibers occurs at 4 distinct areas or domains. Okay, this is in detail study why absence of the dystrophin causes muscular dystrophy. Okay, N terminus. First point is N terminus. That is second part is first part is N terminus. About 250 of amino acids are there. Second one is largest. That is 2,800 amino acids are there. Rod shape like. Third one is cytidine rich domain. C terminus at alpha actinin. And C terminus domain of 400 amino acids is unique to the dystrophic and dystrophin related protein encoded by chromosome number 6. So dystrophin is first detected in human fetus at the age of 11th week. Dystrophin mRNA is normally detected in the cardiac muscles, that is cardiac smooth muscles, and skeletal and brain muscles. The molecular defect in the dystrophinopathies are of various types, like intragenic deletion, point mutations of the nucleotides. If you look into the pathology occurs due to four reasons. One is defective blood supply to the muscles, defective nerve supply to the muscles, defective membrane of the muscle, that is defect in the membrane of the ultrastructure, increased level of the cholesterol in the membrane, that leads to problem with the membrane formation, decreased activity of the sodium potassium ATPase pump. Dystrophin is responsible for connecting, this is a very important statement to understand dystrophies. Dystrophin is responsible for connecting the cytoskeleton of each muscle fiber with the underlying basal lamina, which is present in the extracellular matrix. In other words to say, this is a connection between the inside the muscle to outside the muscle, and thus forming a binding material, okay, connecting material through a protein complex containing many subunits. Okay, so this dystrophin protein contains so many subunits, it forms a network, and this network connects the inside the muscle to outside the muscle. So many nutrients which are coming, so that will be appreciated by the internal environment of the muscles. Okay, what is required internally will be taken from the externally, and in totally it maintains that muscular stability, muscle membrane sacrolemma stability, by acting like a binding material or connecting material. Now, when this dystrophin is absent, the total muscle function will get affected. Absence of the dystrophin fails to integrate the integral proteins and create gaps in the cell membrane. This leads to influx of the calcium ions inside the cell through the cell membrane. That means that the membrane gap, okay, so that should be maintained. There should be minimum and it should be maintained. If it is not there, that gap will be more, binding and connection will be less, and as a result, more and more calcium ions go inside the cell. Hence, there will be alteration in the signal pathways and cause water to enter inside the mitochondria. Now, mitochondrial dysfunction leads to amplification of the stress-induced cytosolic calcium signals and stress-induced reactive oxygen species production. In this cascade of changes, several pathways are involved, and there will be increased oxidative stress within the cell and damages the sacrolemma. And eventually it leads to death of the cell. Muscle fibers undergo necrosis and replaced by the adipose tissue and connective tissue like collagen tissues. So usually dystrophin is a rod-shaped cytoplasmic protein. This is a vital part of the protein complex that connects the cytoskeleton of the cell with the surrounding extracellular matrix. This is also called as dystrophin associated protein complex, which is also called as DAC. Previously also we have about these two words, DAC. Okay, this is also called as dystrophin associated protein complex. I hope now the pathology is very clear why this is happening. Now, look into the investigations. Yes, blood serum CPK levels are increased. CPK-MM is very specific to the cardiac muscles. Levels are increased to the high range in pre-symptomatic status also, including at birth sometime. The usual serum concentrations are 15,000 to 35,000 international units per liter, which is peak level. And the normal value, we know that less than 160. And the other lysosomal enzymes present in the muscles such as aldolase and EST will also increase at times, but they are less specific. Cardiac involvement by the electrocardiography and electrocardiogram, chest X-ray, etc., EMG, muscle biopsy, this part we have already seen. Now looking into the treatment, there is no particular treatment either or cure or arrest of the progression. So aim of the treatment is only to prevent the complications and improve the quality of the life. So pain principles is prevent infections, postpone the ambulation, good nutritional state, and physiotherapy. Some of the treatment which is available is myoblast transfer therapy, which is tried, in which the normal myoblast from the muscle of genetically close relatives, so usually father, is cultured in vitro and injected into the deficient muscles with the expectation that they will form the healthy myofibrils with the normal dystrophies to replace the degenerating muscles. Results are again not encouraging. Even in Ayurveda, we will discuss later, Mamsara Saprayoga is advised. This is almost similar to that. Another important treatment which is given is prednisolone. Daily prednisolone improves the strength of the muscles in the children with the DMD, and this is the only demonstrated treatment of DMD. There is no role of calcium channel blockers or vitamins. Fluoride supplementation can be done if the water is deficient in fluoride. Maxidol, a growth hormone inhibitor, can decrease the degeneration of the muscle to some extent, but it has got its own adverse effects. Anticholinergic drugs like ganglion blocking drugs should be avoided. Obesity, if it is there, because child will be once ambulated, the obesity will be also there, so that should be treated. Then comes contractures. The passive exercise and physical exercise should be encouraged to prevent the contractures. All patients require wheelchair eventually, 1 hour a day. Scoliosis, kyphosis will be there, that should be corrected. Treatment should be done to the respiratory and cardiac complications and also infections. So this is all about the treatment of muscular dystrophy which is available so far. What we can do in Ayurveda, that we will do and we will see in the next class. Now one last portion that is related to BMD is remaining, so that we will cover in the next class. Rather, BMD, we have covered most of the things. BMD is first reported by Baker and Kegner in 1955. The mode of inheritance, again, X-linked muscular dystrophy, recessive type. Gene is located at XP21, same area. Onset of the weakness is late compared to DMD. That is the only difference, slowly progressive. Okay, often the manifestations start by second decade. Typically up to 40 years, the child may survive. Rest of the manifestations are almost all similar to DMD, but is slowly progressive, that's all. Boys complain of pain in the muscles or cramps after exercise may be the first symptom. Muscle strength is relatively normal, but vigorous exercise produces a pain and cramps. Mental retardation, very rare. Incidence is 3 to 6 in every 1 lakh. These patients are prone to hyperthermia also. CPK level in Becker's muscular dystrophy between 2000 to 20,000. It is not like 35,000 as we see in case of DMD. Rest of the investigation and treatment is similar to DMD. This is all about muscular dystrophy. In the next few classes, we will see how we can manage muscular dystrophy in Ayurveda and what is the principle, how to understand muscular dystrophy in Ayurveda in detail. Thank you very much.